So next up is Professor Elvira Bramon, who's Professor of Neuroscience and Mental Health at UCL. She's also involved in Genomics England and NHS around developing this genomics capability. Yep, so I think you'll be well known to Vicky, I guess. Your talk then is going to be on, let me get to the right page, Pharmacogenetics for mental health. Okay, thank you, Elvira. Great.
Hello, thank you very much for the invite and the opportunity to present our work here. I'm going to give an overview of pharmacogenomics applied to mental health conditions. So I also work in the NHS as a consultant psychiatrist when I'm not at UCL, and I treat people who have very severe forms of schizophrenia, bipolar disorder, at severe end of depression. And in my opinion, we face two big challenges where pharmacogenetics might potentially help. One of them is that people with a severe mental illness have big reductions in their life expectancy. So this is very well characterized in the literature, in the epidemiological studies, known as the mortality gap compared to the general population. It's a very big health inequality that's found in all the countries that have done these studies. And contrary to most people's belief, this is actually driven, this early mortality is driven by physical health. So people with a severe mental illness will die of the same things that everyone else is dying of, cardiovascular disease, cancer. The problem is that this is happening prematurely and due to difficulties with physical health. And the other big challenge is that I think it's fair to say my patients don't like to take their treatment very much. They don't like it at all, the majority of them. They don't like to come to see us, and least of all to take antipsychotics or lots of other medications. In fact, the studies show that from people with psychosis, 60% will stop taking their treatment within a couple of years. So these two big challenges, seeing how pharmacogenetics can reduce adverse drug reactions, potentially it could be helpful for dealing with these two big problems. And we've made a lot of progress in our understanding of the genetic architecture of most mental disorders. Most of them are actually quite heritable. This is an example on schizophrenia because it's a study I've been involved in as part of the Psychiatric Genomics Consortium, a very big international collaboration. And last year we published a couple of papers in Nature, which I'll tell anyone who will hear because it doesn't happen very often. So this slide summarizes the latest findings on the genetics of schizophrenia. We can plot the variants that have been identified by their frequency in the population and by their odds ratio for schizophrenia. In green, you've got a handful of copy number genetic variants affecting multiple genes. In red, it's the most exciting and latest data, which are, for the first time, single gene mutations across 10 genes. And these are, of course, very rare, but they have big odds ratios. So people who are born with these variants have a very big increase in risk of developing schizophrenia when they grow up. None of them are fully penetrant, but you can see the odds ratios can be really high. And finally, there's, in blue, the common genetic variants. There's hundreds of them. We all carry some of those, but individually, these variants have very small odds ratios. What is interesting about them is that we can combine them into polygenic risk scores, like a single measure that captures all these kind of genetic predisposition. So polygenic risk scores are pretty good, actually, at detecting risk for schizophrenia, but we think they have also very promising potential in terms of detecting treatment response. Everyone knows how mental health drugs are increasingly prescribed. This is data for England alone. In a year, there were 80 million prescriptions of antidepressants and 12.5 million prescriptions of antipsychotics. This could reflect better recognition, better access to treatment. It could do, but it does come at a price in terms of side effects, some of which are quite serious, like QT prolongation, GI bleeds, obesity. So there is considerable side effects to these drugs. Even the antidepressants, which are commonly perceived as less difficult to take than the antipsychotics, they also have considerable side effects. So in mental health, we have almost a luxury problem. There are more than 20 different antidepressants, a similar number of antipsychotics, quite a few anti-manic agents. So it becomes quite a challenge to really personalize the treatment. So at the moment, all treatment is empirical, except a few places in North America, Europe, like in Holland, they're doing very well. But even then, pharmacogenetics for mental health is really only available in very specialized centers. The vast majority of humanity, if they get access to treatment, it's going to be empirical. So trial and error, trying different drugs. But there's a lot of evidence that I'm going to show you next that pharmacogenetics and genetics have an influence on the response to the treatments. This is a very nice meta-analysis. I wish we had done that study. It's done by it was published in a very good journal as well. And what they did is actually quite a simple idea, but it's really nice. So they looked at key pharmacogenes and the exposure to mental health drugs. And in the top graph, you can see a comparison. The poor metabolizers have vast increases in their exposure to haloperidol. This is highly significant, and the effect size is actually quite big. You know, it's almost 1 standard deviation difference between the means of the two groups, normal metabolizers and poor metabolizers. You see a similar effect of increased exposure for intermediate metabolizers on the CYP2D6. Of course, the effect is milder in the intermediate metabolizers. And these guys systematically looked at multiple drugs and the main pharmacogenes, 2D6 and CYP2C19, and the pattern was very similar, increased exposure if you were a poor or intermediate metabolizer. And of course, everyone knows this, for the majority of mental health drugs, antidepressants, tricyclics, SSRIs, antipsychotics, anti-manic agents, for actually most of them, there are evidence-based guidelines, FDA labels, other labels that advise on how you would adjust for this handful of genes. However, treatment remains empirical almost everywhere. The PREPARE study, I don't need to tell about the PREPARE study to this audience, but basically it showed, it was a massive, excellent, multinational, multi-center randomized controlled trial with a massive sample size of more than 3,300 participants. And they found very consistently that they compared treatment as usual, where compared to treatment of many drugs guided by a preemptive pharmacogenetic test with a panel. And they found clear reductions in the likelihood of having an adverse drug reaction. This study included drugs across the board, but it included quite a lot of antidepressants and 2 antipsychotics. So it's very encouraging data. So you might ask, well, okay, so the PREPARE study looked at many drugs. You can't claim that the effects were applicable to mental health. So this is, again, a very nice meta-analysis done by a Canadian group, Brown and colleagues, who looked at all the controlled trials, prospective controlled trials of antidepressant treatment guided by pharmacogenetics. And all of these studies were intervention studies, and they were looking at comparing treatment as usual with antidepressants versus treatment with antidepressants having pharmacogenetic tests. 10 randomized controlled trials, 3 trials that were prospective but not randomized. And they show a modest benefit for the pharmacogenetic, a significant, even if modest, but clearly significant benefit of the pharmacogenetics-guided treatment. In this case, the outcome is remission of depressive symptoms. So the patients that were offered the pharmacogenetic test were 41% more likely to achieve remission. This literature has limitations. It definitely has. One of them is that none of these studies were able to blind the clinicians. So the clinicians knew what they were delivering. But actually, in fairness, it's actually quite difficult to blind the clinician doing this type of interventions. But there are other problems with this literature. And what about antipsychotics? So this is work done by Nushin Sadulakani, who is a colleague in my team. She's here in the audience. And Nushin has finished a systematic review of all intervention studies that have looked at pharmacogenetics in antipsychotics. 4 studies focused on antipsychotics only, and then another 10 studies were looking at antipsychotics in the context of other drugs, most of them antidepressants. And one of the things that was very surprising is that the outcomes were incredibly heterogeneous. Like each study was doing their own thing. For example, well, I won't go into the details, but we grouped them in domains. So in terms of adverse drug reactions, there was a bit of a mixed picture. Some studies showed that there was an advantage for the pharmacogenetics in terms of fewer adverse drug reactions, like the PREPARE study. There were other studies finding this pattern. But there were also studies showing no difference between the control and the intervention arm. In terms of symptom response, a very similar mixed picture. Some advantages for pharmacogenetics or no difference between the 2 treatment arms. Where the literature was more consistent was on the health economics. So the studies, all the studies that we found consistently said that pharmacogenetic testing for antipsychotics is cost saving. And of course, there are also limitations to this literature. The most kind of obvious one is the lack of diversity. All the studies were done on middle-aged Europeans. There were no studies on children, 1 study on teenagers, and nothing in older adults. And another shocking result for us was that all studies were done in North America or Europe. So no UK study. So we set out to sort of, change the situation. And we are doing one of the first UK studies of of pharmacogenetic testing for antipsychotics. I know I've been talking to colleagues here. I know there's other similar studies in Birmingham and Manchester, but ours specializes on antipsychotics. And the first thing we wanted to do is really develop an intervention that works smoothly and that's acceptable for people with psychosis and their clinicians. That might seem trivial, but actually it's been a couple of years of work, and the pandemic messed it all up. It's really difficult to develop an intervention that works well, but we think we have something now. Then we will look at clinical outcomes, and of course we are going to look at health economic outcomes. We want to know if pharmacogenetic testing is cost effective in the context of the NHS, because otherwise we're never going to get it implemented. And the study design is very straightforward. We are in the process of collecting 2,000 people with psychosis who take antipsychotics. And 400 of them get treatment with antipsychotics with a pharmacogenetic test, and the rest get treatment as usual with antipsychotics. We then collect mostly clinical and health economic outcomes. In terms of the approach, the development of the intervention, we have been trying all sorts of things. We'll try any way of collecting the DNA sample. We've mostly used saliva samples and blood samples. Of course, the patients prefer the saliva samples. We kind of prefer the bloods because we have a bigger DNA yield. But we're also trying cheek swabs, and we're keen to try any approach that is available. In terms of the profiling of the genetics, again, we've tried, I'll say that later, but we're trying arrays, PCR, panel methods. We'll try anything we can. And then we produce a report for the clinician that's based on clinical guidelines, FDA, or other labels, taking an inclusive approach. We look at all the guidelines and try to capture everything we find. But the idea is to give the clinician something that is straightforward. And again, we are trying different ways of delivering the results. Then we ask the clinicians to look at the genetic report, discuss it with their patient, and then apply any changes to the treatment. This can include either switching to a different antipsychotic of the many that we have, or adjusting the dose up or down, or simply offering a bit more monitoring. Antipsychotics have a very nice recommended ways of monitoring them, so they could offer additional monitoring, for example. Or they could continue with treatment as usual. This might seem very light touch and non-prescriptive, but it's actually, you need to bear in mind, this is quite a big paradigm shift for mental health. We don't order genetic testing in mental health. In adult mental health, this is very unusual. So it's quite a big change in approach. And a lot of the clinicians lack training. Some of them feel that they're a bit out of their depth. The recruitment is going very well, and the credit for this largely goes to Rosemary Abidoff, who is the manager and the coordinator of all the recruitment, and is also a researcher in the team. We are recruiting all over England, and we have ethical approval to recruit also in Wales. These are the centers that are most directly involved in the collaboration. And we have recruited so far, actually it's 230 patients and 130 clinicians for now, counting up. In terms of the technologies, this is work that's been done by Marius Kotik, who is also here and who can answer the most difficult questions on the technology. But basically, again, we're trying everything we can because we want to work out. We kind of think that we might need a combination of things, but we're trying everything that's on offer. So for example, in terms of coverage, arrays offer the best coverage, obviously, with almost 2 million variants. But we've had good experiences as well with PCR and multi-gene panels. The coverage is really relevant for diversity. So our sample is very diverse, as I'll show you in a minute. And of course, we are very keen to find a technology that can cover all populations. So there's also, in mental health, we have a big challenge. We absolutely have to work with the CYP2D6, which everyone knows is very difficult to do. So we've had good results with PCR and with multi-gene panels. And traditionally, the arrays have not been able to do the CYP2D6 quite so well, but the latest arrays look very promising. And finally, in mental health, we really like polygenic risk scores, and only the arrays can let us calculate that. So what it looks like is that to produce the reports for the clinicians, we are more likely to use PCR and probably multi-gene panels. But in terms of calculating polygenic risk scores and then advancing our understanding of genes that are not so well characterized, for that, I think the arrays are going to be ideal. And we do find some discrepancies and some inconsistencies especially in hybrid genes in the CYP2D6 or copy number variants in the CYP2D6. And for that, we are planning to do long-read sequencing. So one of the strengths of the study is that it's very diverse. We have a good gender balance. We have a very wide age range. We have ethical approval to do adults, but I know there's colleagues here working with children. It'd be really good to kind of collaborate. I'm very keen to recruit more in older adults because they've been missed out in the majority of previous studies, and we certainly have a nice age range. 32% of our sample identifies as Black British, Black or Black British, Asian or Asian British, other ancestries, multiple ancestries. So we're very happy that it is substantially diverse. And this is work by another colleague in the team, Lauren Varney, and she's been looking at the likelihood of finding actionable variants. When I was applying for grants to do this and was getting a lot of rejections, I have to say, one of the criticisms I used to get is, oh, these are very rare variants, you're not going to find enough, and your study is going to be underpowered. So eventually, I managed to persuade the NIHR and the MRC that there were not going to be any problems with power. And actually, our data shows that if you do multiple genes, you do find actionable variants. So in particular, if you look at there are 8 genes of interest in mental health. If you look at all of those, in terms of these, I would call those the variants of interest. Then everyone in our sample has one or more variants of interest. If you then narrow it down to variants that are actionable because there is a clinical guideline, an evidence-based clinical guideline, then the number is still pretty decent in that more than 93% of our sample have one or more actionable variants. So just to end, there's a lot of myths in mental health. So I just want to say this, that is kind of obvious sometimes, but in mental health, we do have a range of effective treatments. This can be drugs or psychological therapies. But I do believe that genetics is going to help us optimize the use of the treatments that we already have. It's also going to help us identify and develop new treatments. But also, I think really important and perhaps more urgent, make a better use of the treatments that we have. And finally, I'm quite fast normally, so the chair will be happy. So I just want to thank all the colleagues in the team and external collaborators who are here. There's many other people involved, but these are the people kind of more directly working hard on the study. And of course, I'll thank all the funders that have supported us. Thank you.